Hi everyone, I'm Dr. Gabriel Paul Pascual from Legend Review Center, and this video will discuss diabetes mellitus as well as its various categories. We'll also be briefly discussing the diagnostic criteria for diabetes mellitus. So let us begin. Okay, first, what is diabetes mellitus? Diabetes mellitus is a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. So primarily, diabetes mellitus presents with hyperglycemia, and most of its symptoms and as well as signs are due to this hyperglycemia. The categories of diabetes mellitus, according to the American Diabetes Association as well as the WHO, are as follows. You have type 1 diabetes mellitus, type 2 diabetes mellitus, other specific types of diabetes, and gestational diabetes mellitus. So you have 4 categories. So let us begin with type 1 diabetes mellitus. Type 1 diabetes mellitus is due to insulin deficiency, leading to metabolic disorder characterized by hyperglycemia. We know that your insulin is your primary hypoglycemic hormone. With the deficiency of insulin, the glucose levels in blood are not controlled. Therefore, this leads to hyperglycemia. Now, why do patients with type 1 diabetes mellitus develop insulin deficiency? This is due to autoimmune destruction of beta cells by T lymphocytes. So type 1 diabetes mellitus is primarily an autoimmune disorder wherein you have destruction of your beta cells. We know that your beta cells are the cells in the pancreas responsible for the production of insulin. So with the destruction of beta cells, you have a deficiency of insulin. So this is characterized by inflammation of islets, and it is associated with your HLA, DR3, and DR4. Then autoantibodies against insulin are often present and may be seen years before the clinical disease develops. Type 1 diabetes mellitus often manifests in childhood. This is why we call type 1 diabetes mellitus as your juvenile onset DM. And you have here clinical features of insulin deficiency. Of course, there is high serum glucose. There would be weight loss, low muscle mass and polyphagia, as well as polyuria, polydipsia, and glycosuria. Now, type 1 diabetes mellitus patients characteristically have a high risk for diabetic ketoacidosis. Diabetic ketoacidosis often manifests after stress. So if the patient with type 1 diabetes mellitus is exposed to severe stress like an infection, the patient can develop DKA or diabetic ketoacidosis. So we have here the pathophysiology of this diabetic ketoacidosis. In stress, the patient secretes high levels of epinephrine, which eventually stimulates glucagon secretion. Glucagon then increases lipolysis or fat breakdown. Now, with the absence of the hormone insulin, this lipolysis is not inhibited, so it goes on and on. Then eventually you have increased free fatty acid levels in the blood, which are then converted by the liver to ketone bodies. Remember, you have 3 ketone bodies. You have your beta-hydroxybutyric acid, acetoacetic acid, and acetone. Okay? With an increase of these various ketone bodies, the patient goes into acidosis, or what we call diabetic ketoacidosis. So usually, diabetic ketoacidosis manifests with hyperglycemia of more than 300 milligrams per deciliter, an elevated anion gap due to the presence of the ketone bodies, metabolic acidosis, again due to the ketone bodies, as well as hyperkalemia. Diabetic ketoacidosis often presents with small respirations, dehydration, nausea, vomiting, mental status changes, and a fruity smelling breath, which is due to acetone, one of your ketone bodies. Usually the treatment is fluid replacement to correct dehydration, administration of insulin, as well as replacement of electrolyte imbalances. Now let's go to type 2 diabetes mellitus. Type 2 diabetes mellitus is due to end organ insulin resistance. So the problem here is not insulin deficiency, unlike in type 1. In type 2, it is more on the functionality of the receptors, of the insulin receptors of the patient. Okay, so because of the defective insulin receptors of the patient develops insulin resistance. This then leads to a metabolic disorder characterized by hyperglycemia. So this is the most common type of diabetes, representing 90% of cases, and usually it arises in middle-aged obese adults. Obesity leads to decreased numbers of insulin receptors. That is why most of the time patients who have the type 2 diabetes mellitus also have obesity. And there's also a strong genetic predisposition. Insulin levels are increased early in disease. This is because of the defective receptors. So what the pancreas does is that it produces more insulin to compensate for the defective receptors. But later on, the insulin deficiency, the insulin resistance becomes more of insulin deficiency because of beta cell exhaustion. Okay? Clinical features also have polyuria, polydipsia, as well as polyphagia, and of course you have hyperglycemia. But unlike type 1 diabetes mellitus, the disease is often clinically absent. Patients with type 2 diabetes mellitus rarely develop diabetic ketoacidosis. They are more at risk for hyperosmolar non-ketotic coma, okay, which is manifested by high glucose, and this could lead to life-threatening diuresis with hypotension and coma. Ketones are absent due to small amounts of circulating insulin. Your insulin actually inhibits lipolysis. So in type 2, remember, there is insulin production. So this insulin will actually prevent the increased lipolysis, which eventually leads to diabetic ketoacidosis. So you have here a table differentiating type 1 from type 2 diabetes. So type 1 is also known as your juvenile onset DM, or your insulin dependent diabetes mellitus. Type 2, on the other hand, is adult onset diabetes mellitus, or non-insulin dependent diabetes mellitus. Then again, we have mentioned a while ago that type 2 is more common. It represents around 90 to 95% of cases. We have discussed the age of onset. Then you have here also the risk factors. Both type 1 and type 2 have genetics as a risk factor. Okay. In type 1, you have autoimmune risk factors, environmental risk factors such as viral infections, HLA DR3 and DR4. Then, of course, the presence of autoantibodies. In type 2, aside from genetics, you have obesity, sedentary lifestyle, race, and ethnicity as risk factors. This is a continuation of the table. So I've discussed the pathogenesis a while ago. C-peptide levels can be used to aid in the differentiation of type 1 and type 2 diabetes. Your C-peptide, if you remember, is produced whenever proinsulin is converted to insulin. So whenever you produce insulin, you also produce C-peptide. Therefore, C-peptide can be used as an endogenous marker of insulin production. So in type 1, since you have low levels or absent levels of insulin, you also have very low or undetectable C-peptide levels. Whereas in type 2, since the pancreas is still able to produce insulin, C-peptide is also detectable. Then again, we have mentioned ketoacidosis, which is a key feature of type 1 diabetes mellitus. Okay, the next type of diabetes mellitus is gestational diabetes mellitus. By definition, when you say GDM, this is diabetes with onset during pregnancy. Okay, so the mother should not have any history of diabetes mellitus prior to developing diabetes, okay, for us to diagnose GDM. Otherwise, if the mother has diabetes already prior to the pregnancy, we say that the patient or the mother has overt diabetes instead. Okay, GDM is only diagnosed during pregnancy. Now, GDM is usually due to metabolic and hormonal changes seen in pregnancy. A large percent of patients develop diabetes within 5 to 10 years. That is why if a mother develops GDM, the mother has to be careful, okay? Because because there is an increased risk to develop another type of diabetes mellitus within 5 to 10 years. Infants born to mothers with diabetes are at increased risk for RDS or respiratory distress syndrome, hypocalcemia, hyperbilirubinemia, and other complications. This is the reason why in pregnancy we have to screen for GDM. There are complications to both mother and the fetus. So with the early screening for GDM, we are able to prevent or at least decrease the risk for these complications. So for us to screen GDM, usually what we do or what we use is your 2-hour OGTT. Some protocols use a 50-gram glucose load prior to doing the 75-gram glucose load, but for the sake of the medical technology board exams, this is what we teach our students. Okay, so the screening is your 2-hour OGTT using a 75-gram glucose load. Prior to the OGTT, there should be a fasting of at least 8 hours. Then you have here the diagnostic criteria. Okay, when you do your OGTT, usually we collect 3 specimens. So the first specimen is your FPG, okay, that represents your FPG, fasting plasma glucose. After administration of the glucose load, you collect a specimen after 1 hour. Then you collect another specimen after another hour. So all in all, you have here 3 specimens. So for us to diagnose GDM, at least one of the 3 criteria here should be met. Okay. Now sometimes the OGTT can be performed using a 100-gram glucose load. If you use the 100-gram glucose load, you can collect another specimen, okay, or what we call the 3-hour specimen. So all in all, if you have a 100-gram glucose load, you have 4 specimens: FPG, 1 hour, 2 hour, then 3-hour specimen. Then the last type of diabetes would be your other specific types of diabetes. These are associated with certain conditions which are secondary, and this includes your genetic defects of beta cell function or insulin action, pancreatic disease, diseases of endocrine origin, drug or chemical induced insulin receptor abnormalities, as well as certain genetic syndromes. So again, we have 4 types of diabetes: type 1, type 2, GDM, and other specific types. Now lastly, before we end this video, you have here the diagnostic criteria for diabetes mellitus. Okay, so if you're using the fasting plasma glucose to diagnose diabetes mellitus, usually the normal level is less than 100. The cutoff for diabetes mellitus is greater than or equal to 126 milligrams per deciliter. In between the normal level as well as your cutoff value for diabetes mellitus is your level, okay, or your range for impaired fasting glucose or pre-diabetes. You can also use your 2-hour plasma glucose level to diagnose diabetes mellitus. So using this test, the normal is less than 140, the cutoff level is greater than or equal to 200, and your impaired glucose tolerance is from 140 to 199. Okay, the HbA1c can actually be used also in the diagnosis of diabetes mellitus. Pre-diabetes is from 5.7 to 6.4%, and the cutoff value for diabetes mellitus using your HbA1c is greater than or equal to 6.5. Now, for the sake of the board exam, if you're asked what is the preferred test to diagnose diabetes mellitus, that would actually be the fasting plasma glucose. Okay, the random plasma glucose or glucose level collected at any time can also be used to diagnose diabetes mellitus. However, this should be accompanied, the elevations of the random plasma glucose should be accompanied by the classical signs of diabetes like polyuria, polyphagia, polydipsia. Okay, then for the random plasma glucose, the levels are actually the same like the levels for your 2-hour plasma glucose level. So the normal random plasma glucose is less than 140. Diabetes mellitus, for your random plasma glucose is greater than or equal to 200. Then pre-diabetes using the random plasma glucose is from 140 to 199. Okay. However, again, the random plasma glucose is only done in emergency cases. It is still the fasting plasma glucose which is the preferred test for diabetes mellitus. Okay, so that would be it for this video. We hope you have learned something from this video, and if you find this video useful, like this video and please subscribe to this channel. Thank you and have a nice day.